Hi everyone, thank you for coming to today's Sharing Best Practice. We've got a few things on the agenda. I can't see everyone, I'm afraid. So I believe we had Terry Chaplin joining us today. I'm not sure if she's here. Is she here, Lucy?
No, not yet. As far as I can see, Steve is here.
Okay.
Hi, Steve.
So we were going to have Terry Chaplin do a bit of a talk, and then we were going to talk about the various issues that I'm sure a lot of you are aware of around PPE and testing, and also visiting as well. And then Lucy was very kindly going to do a bit of a presentation on the amazing work she's been doing around activities for older people. So whilst we're waiting for Terry, do you want to start with your activities, or?
Well, I was just wondering, as we've got Steve here, and he's very clever in all things, aren't you, Steve? Do you want to introduce yourself?
I'm not sure about that.
You are. Would you like to introduce yourself? And I wondered whether it might be worth just having a bit of a chat, really, how everyone's finding with, visitors coming in and out of the home, testing, the kind of quandaries about PPE. Steve, if I hand over to you just to introduce yourself, and I'm not expecting you to answer every single question, but I just thought you might be a good person to kind of take some of these questions away, if that'd be okay.
Sure, yeah. So hello everybody. I think some of you will hopefully have seen me before. My name is Steve Blandford. I am usually the head of quality assurance for Dedham County Council Adult Commissioning and Health services, or basically all adult social care services, including of course care homes. But since the pandemic, I've also been the lead for the local authority for adult social care, sort of provider response basically. So whenever an outbreak is declared, people in my team have been in contact with homes, hopefully offering whatever support we can muster up between ourselves and all of our colleagues across the health and social care system. And more recently, since about December of last year, I also became the lead for adult social care on testing. So that's mainly me trying to get a toe in and influence the way that the testing programme works and operates across the South West Peninsula, and also taking part in some of the national working groups that have been going on, and volunteering, Devon, and some of you, your services in a number of the pilots that have been going on, which we found to be quite a useful early involvement in those, to get a bit of an insight into how proposals for testing works, particularly across different sectors. And if I can help, and I can answer any of the questions, and I obviously will, but I won't make anything up either. And but I'm happy to try and take things away. As I sort of said, we are involved, myself and colleagues are involved in a number of different networks and national working groups. So if I suspect some of your questions I won't be able to answer, what we might be able to do though is take that away and feed that into some of those working groups, and therefore hopefully in a small way influence some of those outcomes.
Steve, I have a question to start us off, and then I would suggest that, if you have any questions, anyone put your hand up or wave frantically at the screen. We've got about 40 people on the call, which is great. So if you don't feel like you're getting any attention from us, do use the reactions and put your hand up. It looks as if, Steve, we are going to be able to send the LFD kits look like they're going to be changing to smaller packs. Is that from the stuff yesterday? And we might well be looking at being able to send LFD tests home with visitors. And I know technically we're not allowed to, but some of us are at the moment. Have you got any timeline on that, do you know?
I think that's pretty imminent, because it also relates to the sizing of packs that are applied within the community testing programme. So I should imagine that they've got very few, if any, of the previous batch size left, and that you will just automatically start receiving more, greater volumes of the smaller batches to equal the same batch sizes that you've ordered previously. But as I say, they're already doing that for the community testing, because what they try to do is they're batched up in sevens, aren't they? So, and that fits in well generally with the orders that somebody in the community can place. So I would imagine it's pretty imminent.
Steve, just a question from me. if the visitors are testing at home, are they still required to register their tests the same online, the same way as we do on the government website?
Yeah, I mean, anybody who does the LFD should do the national logging through the test and trace. Yeah, absolutely.
Okay, and they would then log that as testing for a social care setting? Yeah.
I mean, I guess, you know, in the same way as they would do now. So I think that has been an issue previously with the, if you select that you're from a social care setting, you're currently required, by mandated on the system, to supply a UON or UIN, whichever it is, which I think we've sort of fed back to DHSC is an issue in other settings, because not all settings like yours in care homes actually have been allocated UONs. So, for example, our social workers who naturally say that they are working social care, they haven't got a UON currently. So I think they're about to remove that. So I would say technically they should, because that's what they've been doing before, isn't it? But in future they may not necessarily have to do that. That would make more sense if they're doing it at home. Otherwise, it kind of pins it directly to you, doesn't it? And
yeah. Okay, thank you.
So Shrian's put something into the chat bar and has a time limit. Shrian, would you like to unmute?
Steve, have you heard anything around the mask operationalisation plan around the Friday changing guidance? Or
sorry, Shrian, I didn't quite catch that. There's a bit of muffling on the line.
Sorry, it's just a silly thing, mask. Have you heard anything around the operations of masks changing based to comply with the PHE guidance of Friday? If we've got anywhere as a county in terms of assisting us to work out how we're supposed to do this in practice?
I'm not quite sure, Shrian, I did hear you quite properly, but is this about doffing of masks, or?
Yeah, it's about the changing of the PPE guidance, which changed on Friday, and which sounds as if it's been referred up. But have you got any more update on that from a?
Nothing further. I know, Shrian, I've been copied into the same email chain that you were. I know, which I guess the positive thing, if there is one from that, is that it's clear that the reasons for the rationale are around guarding against new COVID variants, and therefore the switch to single-use masks, relates to that. So I think the confusion that was then caused by the subsequent change in guidance, I think we're talking about, that was introduced on something like the 6th of April, and then on about the 10th or 12th, it was changed again, which removed a couple of paragraphs that were previously confusing in the guidance of the 6th. But then what that caused is some further confusion around whether or not masks were to be single use or sessional use. So I think if anything, what I've taken away from the recent email correspondence is that the absolute intention is that face masks are to be single-use items. But the final clarification in answer to your question, Shrian, I don't know any more than you at this moment in time as to when a further revision of the guidance will happen. But I guess I would hope it's going to be in the relatively near future.
Okay, so just for the purposes of everyone else on the call then, where we are heading is that for a county-wide risk assessment MDT to be convened before the end of the week, we've got a CCG representative. I believe, Steve, someone would have emailed Quake to us for a Quake representative. We've got DCC Public Health, Sarah Alderby, and we've asked Sally Maltravers from NHS England. So for other providers on the call, we have nursing representation on the call by a couple of coerced people that I've asked to join. But if there's any residential home policy writers on the call that would like to join that MDT, it will be convened at the last minute. But if anyone could message me if they are interested in being a part of that working party, it's on two fronts. One, to produce a plan which we can all follow in order to make this safe if single use is the way to go. The second item on the agenda is the production of a risk assessment to first identify whether the doffing and donning of masks inside a building for your service is actually safe in the first instance. I'm very much in the camp that I don't think it's safe. Jackie, brilliant. Thank you. If you've got my mobile number, I'll put it in the chat bar. Anyone else that's interested in putting into that, please do get in touch, because it's obviously an important issue for all of us.
Thanks, Shane. Feel free to add more stuff into the chat bar if you do want to get involved in that, because I think that would be I think that'd be helpful. Anybody any queries for Steve at all? How's everyone finding visiting? Anybody want to share how they're managing it? Because
Can I just come in quickly about the PPE? Something that seemed to slip by me is that housekeeping staff are, according to the guidance, have to change their mask after leaving each room and entering each room. I've been quite focused on the caregivers. So somebody could potentially be cleaning 15 rooms, maybe not having people in those rooms, and changing their mask each time, which be grateful if anybody's got any clarification or how other people are managing that.
Can I just chip in a little bit? Because we're like everybody else, we're trying to track the trends from what the hell's going on. And from the CAA webinar this morning, there has been a task and finish group. It was stood down because of the period of mourning for Prince Philip, and it's kind of reconvening. So more guidance is expected next week. The indications are the DHSC is not going to back down on single use in relation to personal care for carers, but it is going to back down for any suggestion that domestic staff should be changing masks and PPE routinely on going in and out of rooms. I think it's related to the level, the time duration, and the level of proximity, or the intensity of proximity is the driving factor, and common sense and risk assessment should prevail. But there was a bit of backtracking on the hint that domestic staff are going to have to be donning and doffing the same as the care staff are. So that's all I know from today. So it's kind of treading a middle ground, but hopefully people will be able to use common sense, if there's any there.
Stefan.
It doesn't help though, does it? Because the frustrations continue about the fact that, you know, there's an enormous number of masks. There's still a greater risk seen by many about changing, not having the mask off more than you've got it on. So there's, I don't know how anybody else is feeling, but certainly on some of the fora I've sat on over the week, there's a great deal of frustration about it. Just it'd be interesting to see, just from a show of hands almost, who's put into place the new guidance, who's implementing the new guidance, even if you just wave at the screen.
Is there a 50% button?
Yeah.
If you could do it by your reactions, it'd be quite good to see. I think those who have put in the, who have implemented the guidance are somewhat in the minority. Yeah, interesting. And how are you finding it?
I think it'd be interesting to hear from people that have implemented it, because I mean, from my point of view, my concern is because we're a small, well, relatively small care home, and when staff are doffing in the room, my concern is where are they going to don the new face mask? If we're trying, you know, we've got somewhere a clean area for donning, does that mean they're having to walk through the home without a mask on to get to the donning area? Yeah, because I don't think we should be keeping masks in rooms. But yeah, I'd be interested to hear if anyone has started to implement it. What?
Yvonne?
I've just got Ros with me, our care manager. We have implemented it. So if you want to hear what she's doing, you can.
Yeah, so I have implemented it to start off with for all carers. And so I've got areas around the home now. Probably, I mean, we're a 38-bedded home, and I've got them gloves and aprons and masks in specific areas, sort of probably every 6th room. So every member of staff, they are taking everything off and then coming out, and just before they come out of the room, to the left of the room or to the right of the room will be the clinical waste bin. Then they've got the opportunity, obviously, to wash their hands, make sure all hands are done, because I've got bathrooms nearer to those. And then they, before they go into the next one, don in again.
But we've used a heck of a lot of masks.
Oh, yeah. Yeah.
I bet you have, yeah.
Mm.
And we
How are the care staff coping with that, Ros?
It's quite hard to manage, I will say that, because sometimes if I'm walking past, I might see somebody who might have just gone into another room and they've still got the same mask on. So you have to remind them, because it does take a little bit of time of getting used to, because we've been so used to being just sessional. Although when I say it's sessional, they were changing, like when they went on their break, they'd come back in, they'd have a new mask. But it's a little bit better, I'd say. Today's been better.
Yeah,
definitely.
Nick Webb, you had your hand up, didn't you? What?
Hello.
Thank you, Ros.
We zoned the building. We're a 14-bed care home, category OP, and we got 3 floors, so basically sort of 5 rooms per floor as such. So when we initially zoned the building, we put PPE stations in and hand sanitizer stations, 1 on each floor. But we had our donning and doffing room on the first floor where we basically converted our bathroom, because every room has got en suites, the shower en suite. So we took the bath out of play and made that our donning and doffing room. Well, that's now completely impractical for the reasons you just said, Lucy, in the fact that you have to walk across, you have to walk literally up 2 flights of stairs to use that space. So we're now donning and doffing next to our PPE stations. We've got bins there. The frustration for us is that I've got 2 clients that can ring the bell 15, 20 times an hour. And then I've also got a guy on a pressure mat and a motion detector, and we can be in there 20, 30 times an hour. And that's 30 masks. And it's so frustrating. And also we put the wash station in the hallway so that we weren't going into clients' bedrooms to wash our hands, and we made it all very safe. And now, to get to that wash station, if you're on the first floor of the mezzanine, once again you've got to go down 2 flights of stairs with no PPE on. It's utter madness. I'm sorry to say, it's utter madness. And we trained ourselves for a year to not touch the mask. You know, I wear glasses. I've taught myself to breathe differently now. I wear a mask so they don't steam up. But we're touching our faces, and this is the staff's concern. You know, we're breathing on door handles now without a mask on. You know, whereas we had a routine where we go around every couple of hours and wipe down door handles. How often do we do this now? Because if you're breathing on every door handle as you leave the room, do you then go back and wipe down every door handle? I don't think it's been given anything like enough thought. But they are very frustrated by the whole affair. And the same goes when they go around and do the medication. You know, we're going through 28 masks at a time. You know,
I'd like to see the evidence as well, based on the infection control side of it, because that it just doesn't seem to sort of add up to me. So iPad 2 has talked about medication administration. As far as I understand it, it's not for it's for personal care. So medication administration is not part of that guidance. You would wear a sessional use one at that point.
I was under if you were inside 2 meters, then the mask has to be changed.
It needs clarifying, because we've gone around it a few times, sort of on other forward, and no one really seems to. I think it might be worth us, you know, penning some of these thoughts down and putting them in this letter, you know, that Shrian's putting together, because as you say.
And I attended the Public Health England webinar on Friday and asked some of these questions, and they said they would seek further guidance and come back to us this Friday. So because the guidance says about if you're within that 2 meter distance, but also if you're carrying out domestic duties. So my question, quite similar to many of you, is, you know, if we have someone delivering tea and coffee and coming within 2 meters, you know, possibly touching the resident, should they be doffing and donning for, you know, 30, 40 residents every time they're doing that? And they said if the staff member is touching the resident when they're delivering tea or coffee, just change their gloves.
Okay.
My question is, if someone is, that I'd like someone to raise, is if someone is having double-handed care, which a lot of our residents do require, who takes their mask off in the room and who doesn't? And because if they both take their masks off at the same time and they're within 2 meters of one another, you know, it's just, I don't believe this has had any serious thought at all. And the medication question would come up again, because if most of our residents need assistance to take medication, then that nurse, and what length of time is that going to add to that very time important medicine round that we constantly are told how significant that is. I just don't understand where you're meant to take your mask off. Do you take it off in the room, or do you go into a public area and take it off where someone's walking past with the laundry bin? I don't understand. The science doesn't seem to back up anything, because the whole point of wearing a face mask is to protect others from you.
But it says to only change your face mask if you're delivering personal care. Doing a medicine round isn't personal care.
But then they need to define what personal care is. Because sitting next to someone and assisting them with medication, you're as close as if you're washing their feet.
Yeah. Yeah.
I think it's about having a uniform definition.
I thought the definition was what CQC defined personal care as.
But I think personal care is the red thing, because if you're brushing someone's hair in personal care or you're giving them medication, it's a lot more up close and a much higher risk of giving something that they're going to swallow, because COVID is you know, it's the throat and in the mouth, and I think any form of medication that you're giving somebody is probably more personal than personal care.
Steve, you've got your hand up. Do you want to comment on anything we've said?
Well, I mean, I don't think this is going to help very much, but I have had a number of providers who are treating meds administration as personal care. I don't know that they've necessarily got any further clarity over the definition, but I mean, obviously in terms of the CQC definition, obviously it is part of the definition, but like I say, I think I have had a number of providers who are, you know, encapsulating meds administration within this, which again, you know, adds to the dilemmas that you're referring to. Just, I mean, my reflection on your conversation, I suppose, is you are being put in a very difficult situation, obviously, by the guidance as it currently stands, and of course, every single care home is going to be different. You know, most clients will have different levels of needs, 1-to-1, 2-to-1. You know, care more intensive needs than that even, and I guess it's, you know, for the in the interim, because I don't know that we're ever going to get to a point where the guidance is going to give you absolute clarity about how you implement in each of these instances, because it can't really, can it? You know, it doesn't know what your home looks like, it doesn't know the needs of every individual in your home, and the physical makeup and all that kind of thing of the building. So it's kind of down to assessing each individual situation, isn't it? I mean, I was just reflecting on whoever it was who sort of said about 2-to-1 care example. You know, if the room, depending on the size of the room, you know, if it's safest for somebody to step outside of that room and to doff, then maybe that, you know, you wouldn't ordinarily choose to do that, but maybe in that specific instance, you know, that is, you know, on a risk assessment, the safest mechanism of actually, you know, trying to implement the IPC that you would wish to. But as I say, that's almost like assessing each individual situation.
So where would we stand if we actually believe their risk assessment said that you don't use single-use masks, and our risk assessment says the safest option is to continue as we've done for the last 15 months?
I don't think you're alone in that, Emma, and I think there's a great many homes who've decided to amend their risk assessment to reflect that. There have been some homes that have checked with their insurance companies to check that they are still insured if they decide to do that. And I think watch this space this week on that, because as Jackie said, you know, we're hoping to get some guidance by the end of the week. It'll be 5 p.m. on Friday night or something, won't it? But
yeah, midnight.
Yeah. But certainly, I mean, the email chains that I've seen going around, certainly to PHE, have been pushing very hard to get some clarification on some quite specific questions, such as, you know, the ones you put forward. So I think we just need to keep in touch on the WhatsApp group and support each other, really. Has anyone got any other thoughts? Should we briefly talk about visiting before I waffle on about physical activity? I'm just wondering how people are finding visiting back into the homes. Has it been less painful than you thought? Have you had to implement yet another round of risk assessments and policies and protocols, or actually is it quite pleasant to see people seeing their loved ones again?
It's lovely. It's really nice.
Yep.
The homes feel a bit more alive. They're a bit more active again. It's been really nice.
Yeah, I think we found the same. It's a lot of work, but it's certainly worth it when they see each other, isn't it?
Yeah.
Just a question on visiting. So we created pods we were able to use all winters, which is great. Now we're doing garden visits as well. If we're 2 meters apart, we still need to wear masks in the garden.
Nick, can I ask you to turn your camera off just so we can hear you a bit better, because I think your line's a bit glitchy.
So I'm on my mobile phone because one of my carers.
I don't know about anybody else. I didn't catch your actual question about it.
Yeah, it was a bit broken up.
Sorry, Nick.
So is that better?
Yeah.
Okay, yeah. So we're doing garden visits again now because it's absolutely stunning out there. So if we're 2 meters or more apart, do we still need to wear masks, or ask our visitors to wear masks when talking to their loved ones?
What's everyone else's thoughts?
Because we've stuck with the mask, but there isn't really.
Hello. I believe that if you're in the garden and there is the likelihood that that person is going to touch or hug their family member, then they are to wear full PPE in the garden. So
Okay.
that would include a mask as well.
Okay.
The evidence is fairly good now that it is a sort of an airborne disease, and that would include the garden. It would be my gut, but I have been proven to be wrong on these things. So
I know last year because our home has been open for visitors since April last year. We were doing window visits and the garden visits. And then as the weather turned later in the year, we then had the conservatory visits with a thingy in between. And then we had in October, when we had the next lockdown, so that we could continue the visits, we then had like a small easy pod put in so that we could continue visiting. And that worked really well. But last year, we weren't doing masks in the garden, and I think that was a lot to do with the fact that we didn't have masks for the first few months of lockdown, and being out in the garden was associated, or being outside was associated with not wearing a mask. But I think how things have been changing for all of us now around the touching, I mean, I understand why they have said about the changes with the masks, because the reality is we do touch our masks all the time because they're uncomfortable. They move all the time when we were talking, and we do touch our masks a lot. So I think if you're touching your mask, I understand where that policy has come from. But I do think that as they are saying in the guidance, that if we're within 2 meters of someone and likely to touch someone, then we should be wearing PPE. So I think that remains the same for any of our visitors. And I think on the portal, it discusses that as well, about what you're wearing. We have continued for garden visits as well, and even the window visits, because sometimes the windows are open for fresh air. If the window is closed, and they do it via telephone calls on loudspeaker so that they have the conversation. And if it's a window visit where the window is open, then they wear a mask as well. So even though they are, more than 2 meters away, within the home, because some of them like to lean through the window, so you have to account for every eventuality. So by wearing a mask, you know that you're not going to be breaching health and safety. You're not going to be, making an area unsafe by the other family members wearing their mask. And so far, all of our visitors have been more than happy to comply with that.
Good. Can I just ask, has anyone, because I expect people are doing lots of different things, garden visits, face-to-face visits, but with regards to pod visits, for those who have got them, have you increased the number of of visitors that you're having? Because I know the guidance relates to nominated visitors face to face, but it doesn't really specify anything about you know, visitors coming to the pod. So I'd just be interested to see how people are managing those.
We've kept the same number of visitors to the pod because it's to do with the LF testing. It just takes so long, and we would literally, the way that it would work for visiting, we would be testing someone like every half an hour, and we don't have someone to give up that time for half an hour. And even with the grants that we've had, we certainly don't have enough funding to be able to employ someone just to do LFD funding. So we do only have 2 visitors in the morning, 2 visitors in the afternoon. That works well for our home. Our visitors are happy with that. And anybody else, because you don't have to do LF testing for garden visits and for window visits. So anybody else will do the window and garden visits, and everybody just books in their visits, and everybody's happy to work like that. And to be fair, before coronavirus, we might have had like 1 or 2 visitors a day. Now we're having 4 visitors to the home a day. So for me, there's an increase in visitors, which only benefits the residents who are having them. So as far as I'm concerned, this is all good.
Brilliant. I think there's a question on the chat bar. Is anyone having hairdressers in the home? We are. Our hairdresser is part of our PCR testing. And she also does LFD, so yes, we started having her back last week.
Yeah, same as us. Steve has put his hand up because I ended up having a long conversation with you, didn't I, last month about hairdressing? Not because your hair isn't lovely, because it is.
You're right, yeah. I never thought I'd spend quite so much of my life talking about hairdressing, but yeah, life takes strange turns, doesn't it? Yeah, so when I do a bit of an update on this, because as Lucy just said, we have kicked this around on email quite a bit because of, I think, some concerns that have been raised by one of the local authorities locally around this. But I think now, particularly, I suppose now we're in kind of phase 2 of the roadmap, and you know, restrictions being removed, etc. I've been pursuing this over the last week or 2, and I think we're hopefully reaching a situation of agreeing across Devon, Plymouth, and Torbay a sort of a way forward here, which by the looks of it is likely to support the safe reintroduction of hairdressers into care homes. As you say, some of you are already doing so. I understand, of course, that's already happening in some instances. And we're in the process of developing some guidance for care homes to use, and also from your own perspective, because basically I think what it's going to say is, you know, you ought to be undertaking your own dynamic risk assessment in the same way as the guidance currently exists for visiting generally, and what to have regard for, not to tell you what to do, but to sort of provide pointers, as it were, so you can use that guidance in conjunction with your own policies and procedures, and hopefully something that will help you in that regard as care home owners and managers, and also help you with managing situations for the hairdressers themselves, because obviously they're the other important factor in this, and the sort of things to have regard of and to take account for. So that I'm hoping we're working on that now. We've got a sort of a joint call that happens every Wednesday, where I'm looking to take that next week. Hopefully we'll get approval for it, and then we'll be able to sort of issue that immediately afterwards. But I guess the key message for now is, I think directors of public health are in support of safe reintroduction of hairdressers, and obviously just wanting to make sure that we're providing the guidance that will enable that to happen.
Thanks, Steve. Just one more question on the chat bar about what's everyone doing about residents leaving the home, and obviously the 14-day isolation period after that trip out. I know some of my residents are absolutely desperate just to even walk up the road and, you know, just get some cash out. So just mundane stuff, but they obviously haven't been because of the 14-day isolation. So
I think Jeffrey Cox, you brought this up at the Care Home Forum on Tuesday, didn't you? And I think they're going to go away and look at it, because your point, Jeffrey, was that it seems very unfair for somebody to go to the garden centre and not to come into contact with anybody and then be isolated in their room for 14 days. It seems for the sake of a begonia.
Yeah, I'm running the risk of taking the guidance too literally, and I think our own team are sort of shooting me down in flame and saying you've got to apply some common sense here. And it depends what it is. So I think the guidance being rather kind of broad. So if you're going to a hospital or going to a specific appointment in a destination where you're going to be in close contact with people, then the isolation is the penalty you pay for that trip. But we're looking at trips to the park and all the rest of it, and if we're able to maintain, say, social distancing and that kind of stuff, it was thought to be a bit of a nonsense. So we decided to take a common sense approach and be pragmatic and risk assess it situation by situation. Trips to the park are happening. Trips into the town are more problematic because of the proximity of other people, and you just don't know what's around there. But also got to be mindful of the fact that the prevalence of the infection is dropping like a stone, and it was averaging around 7 to 8, and we've had it up at over 300, 350. So we've got to take account of that. The risk that we're still agonizing over is compared to what it was is you know, it can't be insignificant, because clearly it's still a killer disease, but its prevalence is pretty minute at the moment. So I think that we're starting to be on all these things, you know, PPE in the gardens and trips out to the park. I think we're starting to relax and take a bit more of a pragmatic view than be so literal on the guidance. I mean, going back to the medication, we're not doing that for medication, and we're not doing that with the cleaning staff, and it's really down to length of proximity and how close and how intense. Not for yes, for assisting people with meals and fluids, but not for delivering a cup of tea or a piece of cake or something like that. So, well, we're talking about visiting more than the PPE, but the PPE spills into visiting as well. But we're not sort of really doing anything that's going to trigger the isolation unless it's an outpatient appointment.
Okay, thanks, Jeffrey. Lucy, do you want, conscious of the time, do you want to do your?
Yeah, should we do that? Is everyone happy with that? Okay, let me just.
Steve, thanks for your input. It's been really helpful.
Yeah, thank you, Steve. It's fab. Okay, so let's just. Now, the thing with Zoom presentations is you can't always see people's faces, so I'm going to have to just cope with the fact that every now and then I'm going to ask you to take your microphones off mute. So here is what I think most people think physical activity and exercise is all about, and it's about I don't know what you think, but it's about exertion and sweat, which doesn't really kind of work out very much into sort of the care sector, and certainly into my own life at the moment. So if anybody's managing to look like this at any point in their lives at the moment, well done. So there's something called the Physical Activity Guidelines, which some of you may be very well aware of and some of you may not. I did a master's last year in nutrition, physical activity and public health. And actually, surprisingly, the public health bit became extremely relevant from about February, March last year. But the PA stuff was the bit that I did my dissertation on. And the only reason I'm kind of going with this is I must give some credit to Professor Charlie Foster, because he's a very nice man and helped me quite a lot, who's my supervisor. So to rattle through this a little bit, there's a difference between exercise and physical activity. Exercise is seen as a planned, structured and sort of repetitive thing that you would do. You might go to the gym, you might decide to sort of go for a run, but it's something that you do to improve or maintain an element of your physical fitness. Whereas physical activity is any bodily movement. So if you decide to get up and get down a few times from your desk, if you walk to the shops and bring your shopping back, that's physical activity. If you walk up the hill and back down again, you know, it's anything you're managing to do. There's still a lot of jargon in it because we're talking about academic language here. But so, you know, things like MVPA, you might see bandied around in the media, and that just means moderate to vigorous physical activity. It's still physical activity. You're still going to exert yourself and get your heart rate up, but it's not necessarily seen as exercise from a kind of academic point of view. One of the main things about the physical activity guidelines that the UK brought out 2 years ago now is that they the main crux of it was that they feel that it's a miracle cure. If we could prescribe physical activity, which sometimes it is, we get exercise-based prescriptions, but if we saw physical activity as an actual drug, we'd realize that it actually helps so much more than we already give it credit for. And so the guidelines come out, and they're kind of on a lifespan, so they cover literally 0 to death, and they're grouped into different age groups, including pregnant and new mothers, disabled people, children, adults. So this is where I'm going to get you to take your microphones off mute, because the physical activity guidelines have lots of different things within them, little aspects of it, and some of these were recommended by the Chief Medical Officer and others weren't. So anybody think weightlifting made it into it?
Yes.
Yeah.
Carrying heavy shopping?
No.
No.
Yes.
Yes.
Juggling?
Yes.
Rowing? Not rowing. Rowing can get a bit physical sometimes, but no, we're talking about rowing there. Jogging?
Yes.
Yeah.
Gardening?
Yes.
Yeah.
Anyone who's ever seen my garden knows that there's a lot of physical activity out there. There's a lot of brambles to move. Ballroom dancing?
Yes.
Yeah.
Tai Chi?
Yeah.
There are 2 in there that didn't make it to the guidelines. Anybody got any thoughts?
Bowling?
Any others?
Weightlifting.
Heavy shopping.
Okay, ready?
Hmm?
Rowing and juggling. I still think juggling would be such a brilliant one to put in, but anyway, we'll work on that for the next set of guidelines. So
Juggling what though, Lucy?
juggling PPE.
It's like fire or something.
Juggling bags of masks. So they are all evidence-based. There's various expert working groups who go through all of it, and they look at whether there's moderate or strong evidence for health benefit, and they look at sort of the determinants of physical activity. And in case anybody doesn't use that sort of language, determinant is basically an ingredient or a factor. So when we think about physical activity, we're talking physical activity during work. So certainly for those of us who are on the floor as a care assistant or a nurse, we're doing a lot of PA during our work, aren't we? We're lifting, we're moving, we're walking miles, we're hauling, hopefully not hauling people, but we might be hauling clinical waste. We're moving a lot. So for any physical activity during work is one of those determinants. You've got your leisure and your play. You've got sort of, your dog walking, your cycling, dancing, things like that. You've actually got exercise and sport in there. So you might, take part in team sports or go to the gym, do some running, do some swimming. Household physical activity. Now they've actually measured it, but there's a certain factor to doing housework, gardening, carrying your heavy shopping, cleaning the bathroom is still part of physical activity. So you're still celebrating everyday activity as part of your guidelines. And then there's active travel. Many of us are very desk bound at the moment, but in a normal life, a lot of people would choose to get off the bus one stop earlier and walk the last bit, and they might decide to cycle. Active cities are a big thing in this sort of world, because people are trying to get people to move a lot more. So that's kind of all the kind of various ways that people think about physical activity. Now, looking at the infographics that they put together for the physical activity guidelines, they grouped adults and older adults together, and they're built up. This is the one for us, and you can see that they're broken up. So you have a title at the top, you have all the benefits, particularly chronic disease benefits at the top, and you can see the evidence-based thing there. There's you know that physical activity would reduce your chance of cardiovascular disease by 35%. You've got a couple of positive messages and tags that people pick up on. Every minute counts, make a start today, some is good, more is better, all those sorts of things. It's, again, Shrian will take the mickey out of me if he's still on this call, but he's probably not. It's about gain framing. It's about selling a message so that people think it's going to be a fabulous thing for them, rather than going, if you don't do this, you will die, which is the loss framed version of that. The landing point. So there's a landing point on each of the infographics. I haven't bothered showing you the rest of them, but they all have a main message at the beginning, in the middle, and building strength for all adults is important. Everybody from the age of 35 onwards starts losing muscle mass. So if you can do anything to prevent that, you will prevent other issues later on in life, and particularly building muscle mass is a really important thing, and trying to stem that tide of losing muscle mass from 35 onwards is really important. Your types of exercise are also highlighted. And also you can see in the blue bit there, you've also got, you know, for older adults, reducing the chance of frailty and falls. You know, there's lots of stuff about strength and balance within the guidelines themselves as well. So a lot of words here. I'm not going to spend too much time on that for you, because I'm sure you'll get sent this at the end of this. But the main aspects are that particularly for older adults, physical activity guidelines highlight that you are helping to age healthily, and healthy aging is something that we would all want to do, and particularly from 65 plus, all of this comes into play. Now, for a lot of us, we're looking after people who are much further along that line. They're probably 90, 95, and they probably are further along into the frailty spectrum. And I'll talk a little bit more about that in a minute. But certainly there's an enormous amount of evidence that helps to show that you're helping people maintain their independence. You're helping them with chronic symptoms. Even if they've already got chronic diseases, you will help to reduce those symptoms. You're reducing the risk of falls. I don't need to preach to the converted there about falls and how detrimental they are to the elderly. And indeed, even a significant amount of physical activity can actually reverse frailty. There's a fantastic academic paper where they put a lot of nonagenarians, 90-year-olds, through strength and weight training, significant weight training. They were lifting, you know, proper bars, and they reversed frailty in nearly all of them. So you can even, I'm not suggesting you all go out and buy some dumbbells for your 95-year-olds, but, you know, particularly with some medical help, there are things that can be done. This is a bit of a funny little graph, really, but as you can see, over the life course, and the guidelines are there for your life course. They're there to help you maintain your strength and your independence in your early life. But you can see in adult life that if you start losing your strength and balance, how detrimental that then becomes as you go into older life. And then because in your older life, or in one's older life, we might have more caring duties, and being independent is so important. Things like falls are such an important thing as well, and they're so detrimental not just to you but also to the people that you care for. So just having that kind of element of strength and balance ability over your life course is an important part of it. So this won't work for you on Zoom, I'm afraid, but this is a systems map of how you convince people to move, and it is multifaceted. You know, it goes from transport to communication to finance. It comes down to whether or not, if you're a 32-year-old adult and you need to move a bit more, where you live, how can you get to the nearest place to do some exercise or some physical activity, can you afford to eat healthily, things like that. So we're not just talking about one thing that's going to make everyone move a bit more. It's a very complicated system, but as you can see, we're all part of that system in the care sector. So we're part of helping physical activity. I don't know whether anyone has ever seen this, but Susan Mickey has done quite a lot over the last year about behaviour change. She is a professor of behaviour change, and she's come up with something called the COM-B method. Now, if we think about mask wearing, she's done a lot about this, so about trying to convince the public to wear masks. And if you think about it as a threefold process, people need the capability to wear a mask, they need to know that they need to wear the mask, they need the opportunity to wear the mask, so they need to have access to a mask. They need to be motivated to, why am I even bothering wearing this mask? Why are you making me do this? I don't want to do this. So they need those three things, which then affects their behaviour change. You can apply the COM-B method to lots of different things. You can use it in your setting, in your care setting. And again, it's very academic jargonese, but it is one way that people apply physical activity behaviour change. And it's used throughout the physical activity guidelines. So here's the front page of my physical activity guidelines dissertation, and I did it about the media coverage, and I basically broke down the media coverage of the physical activity guidelines when they were published, from the first day of publishing through to about 6 months, so the 7th of September through to the 7th of March. And I looked at how the newspapers picked up on the guidelines. did they pick up on anything? Did they like it? And what did they like about it? So this is the first day. This is September the 7th. It's a Saturday. Saturday and Sundays aren't particularly great days to launch any news because the weekend papers have already been published and written pretty much. So it's quite hard to get stuff in unless it's kind of a bit sexy. So here's kind of a snapshot of some of the things that that they picked up on. And as you can see, they like dancing and lifting weights, old people being OAPs. So the papers liked weightlifting, all of these things. Tai Chi, they loved Tai Chi. They liked ballroom dancing and they loved heavy shopping and gardening. They barely mentioned pregnant people, new mums or disabled adults. Disabled adults got 7 mentions over the course of the first day across all the papers, and after that they got no mention at all. So disability is not seen as an interesting thing for the media. That reflects on us actually in the care sector, not because we don't think disability is important, but it means that we might have to work harder to get the message across because it's not seen in the media. People don't think that disabled people can move, and they quite often can. There's specific guidelines for that. Social media, quite a lot of stuff done on there. I didn't do any analysis on that because it's a bit of a rabbit hole, but that's kind of the idea of what they covered. But yeah, quirky activity certainly, and particularly bowls and Tai Chi, they really liked that. So 50% of the mentions of physical activity guidelines happened on the first day. I won't go into that. That's all a bit analytical, but you can see like the frequency of adults movement, it got quite a lot. They really liked children and young people. They thought children and young people would be a good thing, and they liked adult strength. So they understood, the papers understood that people would pick up on adult strength, and some of the jargonese like every minute counts and it's never too late. Nice to see that dusting is also part of the PA guidelines because I've got quite a lot of dust in my house. I'm not going to go into this. This is the gaps in the global PA policy, but it just outlines to you and anybody else that's listening that, you know, the physical activity policy across the globe is massive, and there's a huge gap in the media attention on that. And it's actually quite hard to get anybody to pay attention to it, particularly in the media. And quite often this is a diagram about policy drivers, and even the WHO Global Action Plan didn't mention a media plan at all. The Global Observatory on Physical Activity didn't mention a media plan at all. So there's a bit of a divorce between the people who write the policy drivers and the people who publish it, and they're not talking to each other, which is kind of what my dissertation aimed to say. So here is your infographic for your physical activity for adults and older adults. You cannot place a high enough value on strength, balance and flexibility. It is just hugely evidenced, and it's a brilliant thing to do, and you can do that right the way through to people who are bedbound. They reduce the risk of falls, they maintain independent living, and they keep your residents with you a little bit longer if you can keep them moving a bit more. And some of that would be about, you know, even going from sit to stand a couple more times than they possibly do. And you can do this through your activities by aiming to do, with the help of, you know, professionals. I wouldn't just say everybody just starts doing, you know, star jumps in the lounge, but with the help of a physio or an OT, you can do some twice a week or once a week, do some sort of movement and balance. And there's lots of ways we can do that, and we could explore that more in a few months' time if you want to, because this is a bit of a whistle stop tour. Where's my thing? So, frailer older adults. This is a presentation in itself, but basically it's about reduction in sedentary behaviour, and it needs to be light. It needs to be light activities that they can do, but it's about, you know, ensuring that they walk a little bit more than they might want to, or even just helping with the gardening, walking and resting a minute. It's all nice stuff to do. And again, I would say I'm not a medical expert here, so I wouldn't say, you know, start marching everyone around the garden, but you know your residents, you know what they're up to. Celebrate everyday activity is the main one. There's an enormous amount of stuff out there on Google. The media enjoyed the quirky activities, and I don't think there's any reason why we shouldn't. I think we have a lot of fun with all of our activities, don't we? And I thought I'd finish with a few pictures. So rather than think about this these very strong, fit people. Well done to them. And rather than think about this, Marcus, I thought this was a little bit like you in about 50 years' time, actually. But anyway, very, very fit and nubile, and you know, bending over and touching her toes. It's more about this, actually. It's more about, if you can, take the stairs. If you are able to enjoy outside and do Tai Chi or do some light gardening. And then I thought that actually, even for some of our our people that we look after, even some of this is probably a bit ambitious. So I had a little look round and came up with some of these. And actually my favourite picture of all of these pictures, is this one in the bottom, the ladies with the scarves, because actually even raising your arms above your head is actually quite a hard thing to do. And I just thought this was a really nice way of ending, because it shows all the different ways that we can imaginatively put some of those guidelines into practice in our care homes. And I'm sure I'm preaching to converted here, and I'm sure you've got lots of much better ideas than this, but I thought that was a nice way to end.
Thank you.
Any questions?
Can you share the slides, please?
Yes, I can. Izzy, I think, is going to convert them and send them over. That's okay.
That was really good, Lucy. Thank you.
Thank you. Hope it wasn't too patronising.
Yes, it was.
But Marcus, you can touch your toes, you're fine.
I can touch my toes, but that chap was much thinner than me.
And very much older, Marcus. I think you missed that bit out.
No, I didn't notice that bit.
Has anyone got any last questions before we finish up?
Bex is off to do the downward dog. Good for you, Bex. Well, maybe we should end every sharing best practice with a downward dog.
You can do the demonstration, Lucy.
Thank you everyone for coming. Izzy, when's our next sharing best practice? It's in May, there's something, I think.
I think it's the 20th of May.
I was thinking of the same.
Wrong, I will correct myself later. I think the 20th of May.
So the 20th of May at the moment, Jeff.
No, that's the 19th of May.
19th
Sorry, that's
of May. Just keeping it all
19th of May is the Wednesday.
We're going to explore activities a bit more next month. I think there'll be a few more things we'll want to talk about. We'll probably want to fling some masks at each other and work out where we are with life. But I think Jeffrey and possibly a couple of others might talk a little bit more about activities, particularly as we get into nicer weather. If you'd like to contribute towards that, or even just have a 10 penneth worth on that, please do let us know, because we'd love to involve it is about sharing best practice and talking about things that you might do that you would like to tell us, simple things that we could implement very easily into our homes would be fantastic.
And if you have any hot topics or anything that you would like us to cover in these sessions, then please email info@devoncarehomes.co.uk, and then we can incorporate them over the next few months.
Yeah.
Lovely. Thank you very much.
Thank you, everyone.
Thanks.
Thanks, everyone.
Bye.